I have a question, which is not weird in any way. It is a bit of a weird question, but that's not abnormal in any way. So I have to ask, what is half of a thoracic outlet syndrome? TOS. What is half of TOS? Thoracic outlet syndrome. And it's a strange question because real thoracic outlet syndrome, real problems in these areas are a medical emergency and should be treated as such. They need a surgeon and a doctor and a nurse and probably a lot of equipment to deal with. But that's not really what we're talking about. We're talking about how did it become so impinged? How did the structures involved in TOS become impinged? Because it's an anatomic problem. It's a problem with the anatomy. And so we should be able to make sense out of what's happening based on that same anatomy. How did it get there? How did it go from at one point normal to abnormal? There has to be a progression unless it's a traumatic injury, but in the average person that gets thoracic outlet syndrome, there has to be a progression from good to bad. So let's talk about what's basic in thoracic outlet syndrome. Let's talk about the simple mechanics. So we've got a brachial plexus that comes off the neck. There'll be a nerve, and that will form with other nerves, and it'll make all kinds of crazy stuff here, and it'll shoot off in a million different directions, going to everything in the arm, of course, and all the way to the hand, fingertips even. But we're going to keep it as a simple line. Understand that it comes off the neck, and it goes through a number of spaces to get to that shoulder girdle, and then down into the arm, forearm, wrist, and hand. There is also a large blood vessel. There's actually two, but we're going to just draw one. There's the blood vessel, again, for the same structures, arm, hand, forearm, all that. And that is our subclavian axillary portion and then brachial portion. Again, it gets more complex, but we're going to keep it pretty simple. And understand that these things travel together. Just to do a closer up shot, just to make a little more sense out of it. So these are cervical vertebrae right here, the neck vertebrae. And this would be our AC joint, the clavicle, and acromion coming together, whereas this blue structure is, again, the rib. So the nerves come off the cervical spine, and they will eventually go down into the arm. They will go down, again, with a number of different vertebrae, and then just adjusted the layers there. They'll go down with a number of vertebrae. And the artery will follow along with it. It'll be coming essentially off, with the heart, or from the heart, and it will travel that way. It's a little bit bigger. So again, I'm just going to get rid of it just so we're clear, just so it makes sense. Anyways, the first point of problems tend to be between the brachial space and the rib. So there's a muscle called the scalene. So if we were looking at it from the side here in our fuller picture, these triangular muscles, incidentally the scalenes, look approximately like that. I'm just throwing them in, and they go from anterior and posterior tubercles from that cervical spine, and they attach to multiple points, but mainly the scalene tubercles of that first rib. And so you'll notice right away that there is a space constraint here. There's a limited amount of space for the vein, artery, and nerve that is traveling through this region. And so it's not a problem in normal anatomy. How does it get to be a problem in the positional anatomy we're going to talk about? Now, the next space is actually the rib clavicle space, which is right about here from our side view. Again, looking at a close-up, if the blue spot is the rib and the black part is the acromion joint, the clavicle, how does it go from this open space to a much smaller space, one that might entrap a nerve, an artery, or a vein? And really understand that the clavicle, this structure here and that first rib are constantly moving. With every time we swing that arm, with every time we breathe, we're moving both those structures. So it's a simple question, actually. How do we start to change the shape of that space? Another area that comes into question, or the third space where it can entrap this neurovascular blunder, is the Pec Minor space. me just adjust that. There we go. Okay, there we go. Pec Minor is a muscle that goes from the coracoid process of the scapula, so it's right beside the shoulder joint, and it goes to the ribs 3, 4, and 5. And so this chunk right here is where that same neurovascular bundle, the same one the whole way through, is passing underneath that muscle between the ribs again. So the question is, again, how can we start to change the shape of this space? How do we go from normal to abnormal? How do we shrink the space? And the reality is, it's not a difficult thing to explain, because we can do that, and it's often done, in fact, through changes in tissue thickness and as well through changes in bone position. That's how we get these structures to be either too compressed, too close together. It's really simple. It's basic physics, actually. So understand, though, this takes time. This is not a quick thing that just happens overnight, unless there's a horrific traumatic incident. It does take a lot of time normally, but one horrible situation can do it. But I'm going to throw you up just an idea of a few positions that can make this happen. So getting rid of that guy and throwing this up. So just adjusting the clavicle here. So look what we've done in this position. Notice how previously, just for comparison, throw this up, the head has dropped forward. So the head in this picture here has dropped forward, and by comparison, a little bit down. We've actually rounded down. We've come that way. And we've increased our thoracic curve. And with that, the shoulder position has dropped down too. So we've actually gone into what we call a protracted position. And that's clavicle coming that way too, as well as the scapula, this structure here. With that, getting rid of some of this, again, cleaning it up, notice that the thoracic cage is actually, when we really round that thorax, that thoracic spine, the cage actually kind of pops up a little bit with limited space. You can't compress the guts too much because they're right here. So that cage will start to distort to make room for that. And so that cage actually pops up at the top a little bit. It takes it on this wide. If you're looking at it from the AP, the anterior view, you would actually see it as wider from side to side. So this starts to explain things, but we can be a little bit more specific. So let's look at that neck again. Let's look at that first area of potential problem. So remembering that brachial plexus comes down this way, just coming through. And again, we could add the artery and vein, but understand they all travel about the same path. So look what happens when we take on this forward kind of rounded position. The scalene muscles are allowed to come closer together, or the attachment points are coming closer together, because remember, they go from cervical spine to rib, either side, and that nerve comes in between. And so as you shorten a muscle, especially if it's contracting hard, maybe to stabilize this head position, as you contract a muscle over long enough time, it will begin to thicken and harden. It will become more rigid than it previously was. So where previously we had a soft and supple scalene muscle, perhaps we could have a muscle that has thickened to the point where it has lost mobility, and therefore it has lost the ability to give space. And it probably has the fascia around it because of repeated insult for whatever reason, head position again. It is now bigger than it used to be. It is taken on a thickening in the area. This is a relatively well-known thing, and this is why fascial release exists in the first place, this basic concept. And this is as much a chemical process as it is a physical process, but that being said, there are anatomic changes that start to happen. So if we want to close this space off, if we want to bring this and this together to make it so that there's less space for that nerve to pass through there, this is an easy way to do it. In fact, we change that neck position and we change the head position and that rib position all together at once. The rib comes up closer to that scalene muscle. The rib comes up closer to the neck. Alternatively, you could do the exact opposite. Of course, we could bring the head way far back and we can increase the length of the muscles, but that doesn't necessarily increase the thickness. It doesn't necessarily close off this space right here. Okay, let's talk about the next part. So understand that we've already said this, but when we start to drop down as a whole, there's a limited amount of space below. So the ribs actually, though the overall thoracic curvature increases, though it gets that way, flexed as a technical term, though it gets that way, the upper part of the ribs tends to come up a little bit. Remember, this is the clavicle here, and the ribs, again making them blue, just to keep with a consistent theme, are getting pushed generally upward with it, especially at the top. They come up. And if there's a limited amount of space, if they are coming up like so, again in our close-up view, there's a limited space right here for that nerve and that artery to actually pass out through. So this is an easy point where we can start to shorten up the space. If these two are approximating like that, then it's not difficult at all to see how we could make it so there's less movement, less room here for this stuff to pass through. And if they are sensitive to pressure, as a nerve is, and certainly a blood vessel can be very sensitive to being occluded, that's compressed to the point where it can't flow anymore, which can generate blood clots, this could be a problem. You won't notice it, of course. You won't notice it potentially till it gets really bad. There could be warning signs. There's probably people walking around with half of a thoracic outlet syndrome going on all the time, and it's never a problem. But again, what takes it that much further to true medical emergency? Okay, now, last one. Going back to that shoulder position. I just need to get rid of some of this. The shoulder position is a big one, but we can talk about essentially the same thing. So as the shoulder position comes forward, so remember the shoulder was here, now it's dropped forward, so it's taken the scapula with it. It drops down. And again, we get the similar effect. If the attachment of the pec minor is here and the coracoid process gets closer to it, we have shortened up those muscles. And if they are there chronically over a long period of time, especially with improper use, they too can become thicker. And that passageway through here essentially, between the pec minor and the rib cage for this artery and nerve also can become an area of problem because it will thicken like anything else and it will start to put back pressure on that tissue. It will start to put enough pressure to be problematic over time. Understand that these situations are normal. This position that we've demonstrated right here is not an abnormal thing at all. This is a position many people, maybe you yourself, have taken on during times of stress and poor physical health. And maybe it was temporary, maybe it is permanent for you. And this is why manual therapy and fields that look to address the body, correcting its position, ensuring we can get the best mobility and the most sound structural position out of every joint and every soft tissue, they can be very effective at fixing the problem before it gets bad enough. This has been Elge from Simple Lens Anatomy. I hope that helped.